Ladies and gentlemen, today this is a webinar of the European Society of Gynecology that we do in preparation of our next Congress at the end of November, beginning of December in Amsterdam. And today in this webinar, we will discuss about the role of progestogens in luteal phase supplementation and hormone replacement therapy. There are two very important topics that will be covered by Johannes Holt and Alfred Mueck. Johannes Holt is currently the interim head of the clinical division of gynecologic endocrinology and reproductive medicine at the Medical University of Vienna. He's authored of more than 100 peer-reviewed publications in gynecological endocrinology and reproductive medicine, and is a very well-known partner of the European Society of Gynecology. He will have the first talk, and then later Professor Alfred Mueck that I will present after. After the second talk, we will have the general discussion. Please send your question writing in question and answer. You will write the question, we will provide the answer by the general discussion. Now, it's my pleasure to Johannes to introduce you. You have the microphone, you can share your screen, and then you can go on with your presentation, which will be on progestogen in luteal phase supplementation. Thank you very much.
Hello, everybody, dear colleagues. I'm happy to talk about luteal support today. Andrea, thank you very much for having me here. It's always a pleasure and an honor. And now we just start with it, so it doesn't take too much time, but I can give you all the important information. So I have no relationships to disclose. And before we go into detail about the luteal support in IVF and recurrent miscarriage, I will focus on luteal phase defects, because that is what we try to treat with luteal support, presumably. Many of us think that these luteal phase defects are equal to luteal insufficiency, in other words, of a lack of progesterone. However, basically, these defects are characterized by an inability to develop a fully mature endometrium, and thus the main definition is a histologic one and not a serological one. But there are two major mechanisms which have been proposed, namely an inadequate endometrial response to progesterone, as well as an inadequate corpus luteum function. And the latter has been linked to several abnormalities, which include, for example, decreased FSH levels in the first half of the cycle, or an abnormal LH pulsatility, probably the most important one, as well as other factors. And this is what we have in mind when we provide luteal support to a patient. But how is progesterone built in the ovary after ovulation, and on what stimulus is this production based on? What you can see here is that the rises in progesterone, I'm not sure what you can see, yeah, you can see that the rises in progesterone, which are likely due to rises in GnRH, are necessary for a rise in progesterone secretion from the corpus luteum. So the woman on the left side seems to have a good progesterone secretion. And there are two sources of progesterone in the ovary. First, we have the small luteal cells, which you can see on the left side. They derive from granulosa cells, and they contribute to progesterone secretion with a basal production independent from LH. And on the right side, you can see the large luteal cells, which originate from the theca cells, and they respond to LH with an increased estradiol and progesterone production. And that's what they do from the 4th to the 6th day after the ovulation on. Problems with the small cells can be caused by accelerated luteolysis, and a problem in the large cells probably by a failure to respond to LH or in central regulation. And it has been claimed that women undergoing IVF might suffer from luteal phase defects more often due to specific problems, and that's why we usually provide luteal support to these patients. And why do these women probably suffer from luteal phase defects or an improper secretion of progesterone? It could be due to multifollicular development, which would lead to a negative feedback LH secretion via cyprophysiologic estradiol serum levels. It could be caused by the disruption of granulosa cell function after oocyte retrieval, and many more causes have been suggested. And the first most important thing is that it has been demonstrated that the use of luteal phase support with any kind of progestogen would increase the rates for ongoing pregnancy and live birth after in vitro fertilization. However, as also shown in this Cochrane database analysis from the year 2015, the effect is only modest with an odds ratio of about 1.8. And this supports the often mentioned theory that in the majority of patients which undergo fresh cycles, the natural luteal function after oocyte retrieval is indeed sufficient. And as you all know, there are several routes for progesterone administration. And we're talking about the different progesterones, progestogens, and the different routes of administrations today. That's why this is extremely important. So we have intramuscular application, vaginal, subcutaneous, oral, and transdermal. And luckily, we have several good analyses available to compare all these treatment regimens in these schemes. For example, in a good meta-analysis of 2009, to start at the beginning, the vaginal and the intramuscular applications were compared to each other, and the effects on clinical and ongoing pregnancies were comparable using these two regimens, whereas the data favored the intravaginal progesterone in terms of the reduced miscarriage rate after IVF. It needs to be emphasized that in these times, with these analyses, the progesterone gel was used instead of capsules that we're using nowadays, usually. But based on these studies, it has become kind of a routine to make a vaginal application of progesterone, either using gels or more usual, the capsules. However, in the last years, experts have discussed whether oral dydrogesterone would be more effective or at least as effective as vaginal micronized progesterone. How come? According to a meta-analysis in 2016, which I'm showing you here, both regimens would be similarly effective in terms of clinical pregnancy rate. You can see this on this slide, but the more important slide here is, of course, when it came to the data about patient satisfaction and dissatisfaction, it was clear that the data favored oral dydrogesterones because, of course, the application is more convenient to the patient and leads to less dissatisfaction than the vaginal application. And 2 years afterwards, we were lucky that Professor Griesinger and colleagues were able to publish their large randomized study, and they will finally show that oral dydrogesterone was non-inferior to vaginal progesterone. Of course, that's a large study, a study which was needed to show that, but it showed that oral dydrogesterone would be as safe and efficient as the vaginal progesterone in fresh IVF cycles. Although we can say that the majority of preparations used to seem to similar conception live birth rates, many experts can rely on these data. And nowadays, oral dydrogesterone is seen as reliable as vaginal micronized progesterone, and of course, thus used in many institutions. And this is, of course, evidence-based. I just wanted to focus on other treatment options for luteal support shortly. It's not taking a long time. Due to its structural similarity to LH, HCG has been claimed to be useful, which is also suggested by the already mentioned Cochrane database analysis from 2015, with a moderate odds ratio of about 1.8. However, it needs to be emphasized that these data are comparing HCG to placebo and not to progesterone use, so we do not have reliant data to compare these two treatment regimens to each other. When progesterone is already provided for luteal phase support, there are data that additional estradiol treatment does not seem to increase the pregnancy rates, and this is important, additional GnRH agonist treatment might improve pregnancy rates. So that might be a good idea especially in women where you have the feeling that your normal luteal support might not be sufficient. There is an even more recent meta-analysis on this topic, and this also demonstrated that the combination would be favorable, published in 2020. The administration of GnRH for luteal support not only significantly improved the live birth rates, the clinical pregnancy rates, and the ongoing pregnancy rates, but also revealed a tendency to a decrease in miscarriage rates. So many institutions should think about doing this for the patients. And probably this will become even more important in the future, since we're going to get more, probably also orally available treatments for that. Do we also have reliable data for elective frozen cycles? Because probably that's completely different, because many of us are doing these cycles in a natural cycle or a stimulated cycle. Unfortunately, we do have reliable data. We are having a recent meta-analysis from 2021 here, and you can see that the progesterone luteal phase support was associated with a higher clinical pregnancy rate, odds ratio of about 1.5, and even a higher live birth rate, with an even better odds ratio of about 1.67. By the way, which is not shown in this slide, HCG did not lead to an improvement here. Similar results were found for natural cycle frozen embryo transfer in an even more recent meta-analysis. Importantly, the authors also focused on the differences between oral dydrogesterone and vaginal progesterone once more. As I said before, this is about frozen cycles, and both seemed equally effective to achieve lower miscarriage rates and higher pregnancy rates. So the second topic will be about recurrent miscarriage. This is very important because we've been thinking about luteal phase defects and luteal insufficiency in recurrent miscarriage for many, many years and decades. And you probably all know that the higher the number of previous miscarriages in women with recurrent miscarriage, the higher is the risk for a euploid miscarriage. And the higher, that's the idea behind it, the prevalence or the incidence of luteal phase defects might be in these women with more previous miscarriages. There have been several studies trying to evaluate whether luteal phase defects are common in women with recurrent miscarriage, and the prevalence reached nearly 30%, up to 30% in reasonable studies. Some studies showed us even higher, but I don't believe that these data are true. But still, the question is, when you remember that there are several reasons why a woman can develop a luteal phase defect, the question is whether we can help all these women with luteal phase support only. However, luteal phase support with gestagens is the main approach. Again, we're having the very important PROMISE trial, which had long been awaited, and 2 vaginal capsules of 200 milligram of micronized progesterone was used in a randomized fashion, but very interestingly, did not lead to a beneficial effect in women with recurrent miscarriage in the whole population. But it did lead to such an effect, especially on ongoing pregnancy rates after 12 weeks in women with 3 or more previous miscarriages, especially these patient populations where we do believe that the number of aneuploidy decreases and the number of luteal phase defects probably increases in these women. And the same was true for a reduction in further first trimester miscarriages. From my personal experience, we're having 2 kinds of women who are counseling us and who are seeking information from us. The ones who want to achieve a live birth, and from my personal experience, there are several couples who are saying, I would like to have a baby, but what is most important for me is that I do not suffer from another miscarriage, because this is a devastating state and absolutely burdening. And that's why I think we also have to know the data about further risk for miscarriages. What we can say from a recent meta-analysis is that it is very likely that the use of progestogens increases the chance of ongoing pregnancy or live birth in women with recurrent miscarriage, at least in those with 3 or more previous recurrent miscarriage. But the question is whether any kind of gestagen would be favorable over another. For example, some guidelines still recommend oral dydrogesterone over micronized progesterone based on several older analyses. And it needs to be emphasized that this Cochrane-Netzer work meta-analysis, which was published in 2021, was a very important one in my eyes. And it said, and it stated, that the dydrogesterone would not increase the chance for an ongoing pregnancy in women with a threatened miscarriage and at least 1 previous miscarriage, but importantly, the vaginal micronized progesterone would do so. In recurrent miscarriage, in these large analyses, none of the substances was found to increase the chance of a live birth. I'm aware of the fact that several meta-analyses show different results, and that this is a question of the studies which you would include. Personally, I changed the treatment regimen that I'm using to vaginal progesterone only within the last year. So last but not least, what patients are also worrying about is whether the vaginal application of micronized progesterone would be safe for the further course of the pregnancy if the progesterone was provided within the first trimester. And what you can see here, it is safe. So the most usual complications are not increased. Moreover, it also reduces the risk for preeclampsia, notably, according to this also very recent meta-analysis. So I hope that you were able to take something with you. I'm very sorry, it's a very complex topic and many information just provided in a few minutes. I hope that I could give you a concise overview, and I'm looking forward to the question sessions afterwards, and thank you for your attention so far.
Thank you very much, Johannes, for that beautiful lesson and the complete presentation of data on this very interesting topic. And then now we will have the second presentation, and then later on the discussion. The second presentation will be done by Professor Alfred Mueck, who will speak about the choice of progesterone in hormone replacement therapy. Professor Alfred Mueck is professor of OBGYN in 2 universities. It is professor at the university professor in Tübingen and professor in Beijing. He's a very well recognized, scientist in the field of steroid and the effect of steroid on human reproduction, and also for some very important biological studies on estrogen and cancer. And Alfred Mueck, he will now speak about on the effect of progesterone in luteal phase supplementation and hormone replacement therapy. Please, Alfred, you have the microphone and you have your slide that I have already seen. They are starting. Please.
I thank you very much for your nice introduction, Andrea, and I'm happy to participate as a speaker at this important webinars. As you told at the beginning, I have the experience in the Western world with Western women and also in Chinese women. So some is the same, some is different. And I'm really working since many years in the field of HRT. So in Germany, I was for 10 years the president, and now I'm honorary president for life. And in Germany, the number of participants in the 10 years increased from 300 to now 3,000. And also in China, I was active. We established the first menopause clinic, the first official menopause clinic in China. Now in China, there are about a dozen menopause clinics. I want to start my lecture with a very important statement that the primary indication for progestogen addition is to avoid the development of estrogen-dependent endometrial cancer. So we can treat without the progestin in hysterectomized women. And for this treatment, we have two different possibilities. We can have a sequential treatment with HRT. That means first the estrogen, then estrogen plus progestogen. And we can have also continuous combined treatment. That means every day estrogen and progestogen. In some women, we can treat with progestogen only in the early menopause. Especially, I use this regimen when I only have bleeding problems. Now, the classification of the progestogens can be according to the chemical structure. There we have three groups. We have 19 testosterone derivatives. We have the derivatives from the progesterone, and we have one from spironolactone. This is the drospirenone. Now, in the clinic, mostly important are special properties of the progestogen. For example, the anti-androgenic properties. These properties are different. For example, anti-androgenic strongest property according to experimental research has cyproterone acetate, and also deonogest, drospirenone, and clomidinone acetate we can use if we like to use the androgenic progestogen. I will use this example to give you one example that not always the so-called gold standard of HRT may be the best therapy. Gold standard mostly is described that it is transdermal estradiol combined with progesterone for several reasons, which I will show you in this lecture. But a different choice can be recommended in special situations. For example, if you have situations of hyperandrogenemia, like in PCOS, metabolic syndrome, and often also in diabetes, it might be better to have an anti-androgenic progestogen, which block the androgen receptor, and to give oral estrogens instead of transdermal estrogen to increase SHBG, and this can decrease. This can increase the free testosterone, and this can decrease the free testosterone. And with this, you can also have a better treatment than with transdermal estradiol compared with progesterone. Now, the other actions on the receptors are, for example, the action which is called anti-estrogen action, and this is the action especially in the endometrium. All progestogens have this action. Then we have androgenic action of some progestogens derived from norethisterone, which are not so important in HRT and also not in contraception. The anti-androgenic action is important, sometimes also the glucocorticoid effect. If we have this effect, like with CPA, we should monitor glucose metabolism, and I do not use it in PCOS or in other patients which have strong glucose metabolism. And important is also the anti-mineralocorticoid action, especially also important in contraceptives, because this action means that aldosterone is antagonized. If aldosterone is produced by the angiotensin II, it can stimulate in the renal action the sodium and water sodium and water reabsorption, which can lead to hypertension and to edema. And this effect can be avoided when you give the drospirenone, because the drospirenone directly blocks the aldosterone on receptor level. So you have less problems with hypertension, and this is a beneficial effect. And indeed, there is a large study that we have less risk of stroke using drospirenone in HRT compared to other combined oral HRT products. But the other thing is what often is forgotten in HRT. We know it in contraception, but maybe also important in HRT. If you block the sodium and water retention, you have a higher risk of exsicosis, and this is a risk factor for venous thromboembolism. So using drospirenone, you have a higher risk of venous thromboembolism. So you have a benefit in the arterial system, but not in the venous system. I give another example, what should be considered in the pharmacology of steroids, also is forgotten often. It is the pharmacokinetics. The progestogens have different Cmax, different area under curves, and can have with this also different clinical action. For example, in the very famous studies with the monkeys, where they have shown that the coronary plaques are reduced, adding equine estrogen to these monkeys. And this effect is a very important effect for cardiovascular protection and is totally antagonized if you give MPA once per day. But if you give it twice per day, that means you have lower Cmax and lower area under curve. The beneficial effect of estrogen is not antagonized. So indeed, we should always also see the different pharmacokinetics when we give the progestogens. Mostly this is not made in the clinical field, but has importance, as I have given you just one example. What mostly is important for the choice of the progestogen in HRT are the four main risks which we know from the HI study. This increased venous thromboembolism, increased risk of myocardial infarction, stroke, and breast cancer. And these are the four main problems which we have. And I will go systematically through these four risks and show you the main risk coming from the estrogen component and coming from the progestogen component. Now, for VTE, venous thromboembolism, is very clear. If you give estrogen orally, you increase the risk of VTE, but also the progestogen component can further increase the risk of VTE. And in the experimental research, we know this, that the estrogen can increase the coagulation in the liver, and this makes the increase of VTE clinically, and the progestogen can decrease the fibrinolytic activities. There are differences between the progestogens regarding this effect, can make a dilatation in the veins, which leads to a stasis, which is also a risk factor for the VTE. So we have mechanisms in the experimental field which can explain that we have an increased risk with estrogen, but also with progestogen. In the clinical study, we have from the transdermal therapy, at least 5 studies showing that there is no increased risk of venous thromboembolism when we use the estrogen transdermally, which is logically because we have no increased risk of coagulation. But I would say we will have studies also with an increased risk with transdermal estradiol, because not only the hepatic effects are important are also direct peripheral effects, which are the same with transdermal estradiol and with oral estradiol. You know, the Virchow trias is increased risk of VTE is by hepatic increased coagulation, by stasis, and by direct effect in venous. And when we have transdermal instead of oral, we exclude only the hepatic effect. So if we have an increased risk of immobilization, stasis, we should also not use transdermal estradiol. Now we see from the HI study the difference between estrogen only and giving estrogen plus MPA. We have an increased risk of VTE in the estrogen only arm of HI, but we have a double increased risk in the combined arm. And this is clear, the result that MPA further increases the risk of venous thrombosis. We also have studies showing that we have ester study, an increased risk with norpregnane progestogens, but not with pregnane progestogens, especially not with micronized progesterone. And the same result is in the E3IN study. So this is also clinical evidence that there are differences between progestogens regarding the VTE risk. Now, regarding myocardial infarction, we have first to say that we have about 30 studies, observational studies, which show us that estrogen can protect from myocardial infarction if we start this early. And this was not in the HI study, because in the HI study, they started the estrogen in older women. The middle age was more than 60 years, and the population had to 50% already high risk factors for myocardial infarction. So you cannot really compare the effect regarding myocardial infarction with other regimens of HRT. So we can really expect, if we start early, this is called to start in the window of opportunity, then we have a protection of myocardial infarction. If we start later, we have an increased risk of myocardial infarction. There are different reasons for this. One is that we can have with estrogens also a so-called destabilization of arterial plaques. This is the main mechanism for stroke. I will come on this later. What is clear is that progestogens can make a vasoconstriction, and this can increase blood pressure, and this can increase the risk of myocardial infarction. So in the experimental research, we clearly have many research about progestogens on vascular systems. I would say about 1,000 experimental studies with different endpoints showing us that there are differences between the progestogens regarding their potential for vasoconstriction, for metabolic effects and other direct effects in the vasculature. I give here one example again with the monkey studies on coronary plaques, decrease of the coronary plaque size when we give the estradiol. When we add the progesterone, the beneficial effect of estrogen is still there. If we add the MPA, the beneficial effect is totally antagonized. And I already told you at the beginning that when we give the MPA twice per day, then we have no problem. The beneficial effect of equine estrogen is still there. So this was the example that we also have to consider other properties of the progestogen. Now, the clinical studies of myocardial infarction, I told you we have more than 30 observational studies. I give here one example of a large study, about 700,000 postmenopausal patients, where we see there is no increased risk of myocardial infarction, even a decrease of risk. Here was it significant with transdermal estradiol. It was almost significant with oral estrogen, but we see if we add the progestogen, the effect can be antagonized. And we see this effect also in the HI. When we have the estrogen only, we have no increased risk. If we give it in the combined arm, we have an increased risk. But this increased risk in HI, which is important, was only seen in women where HRT was started 20 years after the menopause. I can tell you I have treated in my life certainly thousands of women, and I have also participated in many studies, but I very rarely start HRT for the first time in a women older than 20 years after menopause. When I start this, I make the carotid Doppler, I look at other risk factors, and I'm very careful about this because I know older women can have the same risk regarding myocardial infarction like for stroke, and this risk for stroke is with estrogen and is also with progestogen, and is mostly derived from one mechanism, which is the destabilization of arterial plaques. Arterial plaques in the arteries work with special transmitters, and one of the transmitters are metalloproteinases. And it has been shown if metalloproteinases are activated, then the plaque is destabilized, and we have, with the destabilization of the plaque, the risk of ischemic stroke. And it has been shown when we use transdermal estradiol, the MMPs are not destabilized. So it is from the experimental research logically that we have no increased risk of stroke. The question is, how does this work? Because transdermal estradiol, like with oral estradiol, have the same blood levels. Now the reason is that transdermal estradiol in the liver does not increase certain mediators which are inflammatory mediators, like C-reactive protein, CRP. And if inflammatory mediators are activated in the liver, they go into the arteries and they inactivate the MMPs, and this makes the destabilization of the plaque. And this is avoided by transdermal estradiol. In our experimental research, we have shown that also progestins in different ways can have this activation of plaques. So there is a difference between progestogens. In this publication in menopause, we have shown that MPA have this efficacy, but not progestogen and not also testosterone. Now, the other mechanism for stroke risk with HRT, I already have told at the beginning, it is the increase of aldosterone, which can lead to hypertension, and hypertension is the main risk factor for stroke. And this mechanism we can avoid when we use transdermal estradiol, because transdermal estradiol does not increase renin substrate. Renin substrate is the same like angiotensinogen. And the second way to avoid this is to use a drospirenone, which can block the aldosterone receptor. So it's a good choice to have it if there is no risk in the venous system, because drospirenone I would not use in women who have a higher risk of VTE. And the other mechanism I told you is the destabilization of arterial plaques. And the mechanisms of progestogen is the arterial vasoconstriction. All synthetic progestogens, we have published about 10 papers about this. All synthetic progestogens are able to make a vasoconstriction, which you can measure, for example, by blood flow measurements, especially high dosages of MPA. So in contraception, I am very carefully with MPA intramuscular, because this can make a very strong vasoconstriction. And in contraception, I never would use intramuscular MPA in women with increased arterial risk, so in women who have hypertension or stroke. So the vasoconstriction with synthetic progestogens is a very important effect, and is not seen with progesterone and not seen with testosterone, as we have shown in several studies, and also people have published this. And the other mechanism is the destabilization of arterial plaques, which is also different for the different progestogens. Now, the risk of stroke in clinical studies, we have about 5 large clinical studies, cohort studies, and also case control studies showing that we have an increased risk with synthetic progestins, but we have no increased risk when we have the progesterone or the testosterone. We have once with transdermal estradiol, we have only in one study, in one French study, an increased risk where transdermal estradiol is used in a dosage higher than 50 microgram per dosage. So we should, in women with risk of stroke, we should not use transdermal estradiol in dosages higher than 50 microgram. Now, of course, the most important risk is the risk of breast cancer. And we know if we have already breast cancer cells and we give the estrogen will proliferate the breast cancer cell, and at the end, this can get cancer. We have no demonstration of any carcinogenic risks that estrogen by itself can produce breast cancer cell. This is a very important question. We have investigated it in several publications. In the next climacteric issue, we have published together with Professor Rand that certain estrogen metabolites may increase the risk of breast cancer cells, but only if there are additional factors. All in all, we can say that estrogen is only a problem if we have already pre-existing breast cancer cells, and estrogen alone will proliferate slowly. It takes about 10 years to develop breast cancer, starting from one breast cancer cell. Now, the problem is that when we add the progestogen and we have certain cell conditions, the progestogen can increase the proliferation rate more than 10 to 100-fold. So we have very different proliferation rates giving synthetic progestogens to estrogen, but this depends on certain cell conditions, which must be in addition to the progestin acting in the breast. Now we have also experimental research and also clinical research showing that estrogen even can protect from breast cancer. Most famous is the WHI estrogen only study, where we see a protection from breast cancer risk. But progestin addition to estrogen also in WHI did give an increased risk of breast cancer. So the choice of progestogen and HRT will certainly mostly depend on the breast cancer risk. And this is shown in experimental research. We have here a collaboration project from our university in Germany with Beijing, and we have enough patients also now to make the clinical research, about 100,000 outpatients every year in the department of Professor Run. And Professor Run here was in my unit in the lab already 10 years ago. And this was the time when we started with a breast cancer project and showed that there are large differences between the progestins. And now we have, because we have so many patients, we can have subgroups of patients, obese patients. Also in China, we have obese patients and other patients where we see different risk of breast cancer, and we can investigate breast cancer tissue in different ways and look which conditions may be important for an increased risk with HRT. And it is the same in China, like in Western world, that the first question mostly from mother and from the daughter is, how is the risk of breast cancer? And what I can really say that we have in own data the possibility to compare experimental and clinical data for all available progestins. And we started our research 10 years ago, especially for one mechanism, which is dependent on membrane receptors, because Frank Stanzik, famous pharmacologist in USA, made an editorial on our first in vitro results and discussed that the risk seen in WHI may be explained by those receptors. So it may be that a large part of the population in WHI had this receptor, which increases the risk of breast cancer. And a dozen studies have shown that this receptor really makes a very important mechanism in the development of breast cancer. There are two functions. The first is it increases the proliferative effect of certain progestogens. So we have seen a large increase of proliferation with norepinephrine, but not with progesterone, a little bit with testosterone. And the second function, there are certain mechanisms where we have resistance mechanisms which are dependent on this receptor. We have in vitro studies showing this with different cell cultures. I will not show this. We have also investigated the mechanisms regarding genomic and non-genomic effects. So just published that the effect is, the mechanism is dependent on PI3K ACT pathway. And we have also different cell cultures. Is also important. It's important to have different cell cultures The next step from in vitro was to animal studies. So we have different animals and different models. The animals got the tumor. The tumor was infected with the membrane receptor, and we had also placebo pellets. So we had indeed double-blind, placebo-controlled xenograft studies showing that there is an increased proliferation in the animal, in the xenograft, when we add norethistone or MPA, but not with progesterone, and not so large, a little bit with testosterone. Now, the clinical studies regarding breast cancer risk is that we first can say that we have now really the option to measure the PGRMC1 in the not only in the breast tissue, what we did first, we have now also the possibility to measure this receptor directly in the blood and can correlate it with the risk of breast cancer and also with the tumor properties. And so we could show and have published this, that when we have an overexpression with this receptor, the tumors in patients, also these are patients with breast cancer, are larger, have more lymph node metastasis, the survival is poorer, and also disease-free survival is poorer. So dependent from clinical parameters, we could say that the membrane receptors, and they are different, we are just looking at different ones, they can predict the properties of the breast cancer, and measuring this in the blood, which we have here just studied, can predict how good will be the how the properties of the tumors will be, and how should be the further therapy. For example, here in this publication, we see that in cancer patients who have a higher concentration of the receptor in the blood compared to control healthy patients, and with a higher stage of breast cancer, we have also higher concentrations. So this is a clear, good predictive marker. Now, of course, when I speak about breast cancer risk and HRT, we always have to start with the WHI. We know in the combined arm with WHI, after 4 or 5 years, we have an increased risk with breast cancer compared to placebo arm, but in the estrogen-only arm, compared to placebo, we had a decreased risk of breast cancer. And after 18 years of follow-up, still the same situation, an increased risk of breast cancer, a decreased risk of breast cancer with estrogen only. So it seems very clear that at least MPA, and the same is with other synthetic progestogens, can increase the risk of breast cancer. I know 5 studies where we have shown that, where it was shown that progesterone or testosterone up to 8 years can decrease the risk that breast cancer is developed. And based on those observational studies, these are only observational studies, so we should carefully look on these results, and we hope that we get more studies on this. But the statement of the IMS was that micronized progesterone and testosterone may have a better profile on breast cancer than synthetic progestogens, at least up to 5 to 8 years. Now, to finish this chapter about breast cancer, the meta-analysis, which was published 2 years, 3 years ago, the largest meta-analysis which we have, they compared 140,000 women with breast cancer to more than 400,000 women without breast cancer. Now, a very large meta-analysis. And in this analysis, there was also an increased risk of breast cancer with progesterone and testosterone. But when you look in detail, it was only not in the direct publication, but in another additional paper on this, where we could see one table that in this meta-analysis, all in all, only 50 women out of 140,000 had breast cancer and were treated with progesterone. And from a statistical point of view, it is nonsense to make any statistics and any conclusion on progesterone out of this meta-analysis. And the other is that about 40% of the data from this so-called large meta-analysis came from the Million Women study. And the Million Women study is a very bad study. Together with Shapiro, who died 4 years ago, he has been our friend. Together with him and Stevenson and Farmer, we had a series of publications on breast cancer, and one part was also the Million Women study. And our conclusion was that the Million Women study is one of the most worst studies, and there should be no conclusion at all from this study. I have not the time to go in detail on this. The primary problem is in the data collection and in the further monitoring. It was not really clear which HRT, how long HRT, which regimen was used. So we should have no conclusion at all. And this was also now in the editorial of Stevenson and Farmer on the meta-analysis, where Stevenson Farmer again told us by this very good editorial that we should not look more data analysis, because we have the problem of the Million Women study like it was at the beginning. Now the risk is very low in absolute numbers. It's about 1 per 1,000 years. So we should always compare the risk of breast cancer with the benefit of HRT. So we have the risk, the 4 risks, which I go on, but we should compare all the risk also in absolute numbers. I will conclude my lecture on this, what I told at the beginning. First, I want to conclude that the so-called golden standard was clear for me already 10 years ago. And in the last 10 years, we had not many studies more. So we can conclude that this is a golden standard when we have the cardiovascular action. And I was really very happy that in this excellent paper by Shanasani et al., there was the same conclusion. We have a golden standard, but we are happy that we have also other regimens of HRT with a differential use. So I really was happy that we got the same conclusion 10 years again. And I will again say that we have certain situations which may be important, like patients with diabetes mellitus and hyperandrogenemia, where maybe oral estrogen with anti-androgenic progestin may be a better choice. So it is a choice. What is always important to look at the endometrial action. So when I have a problem with bleedings, I make the progestin challenge test, and then I look at endometrial action. And we have summarized the endometrial action of all available progestogens in studies and also in the experimental field, which was published in Climateric. And in this summarizing the endometrial action, we stressed that the endometrial action of progesterone is lower than the synthetic progestogens, for example, the transformation dose. And we see indeed offer bleeding problems with progesterone compared with synthetic progestin. So we have to make something when we have these problems. And because Chinese women have much more bleedings than Western women, we had outpatient hysteroscopy now in China. And from this, we know really very good the different actions of the progestogens. And we have published a table where we make the recommendation of the dosage of the all available progestogens together with transdermal estradiol, low dose, medium, or high dose, which is important if you have bleeding problems. If you have no bleeding problems, it's not important. So I want to thank my people in my friends in China for this cooperation projects, allowing me to make so many publications. We got the highest award for this research from the Premier in China. And I want to thank especially Professor Rand and our team in the Department of Gynecological Endocrinology. Thank you for your attention.
Thank you very much, Alfred, for that fantastic lesson, and then for all the information that you're bringing us about the use of progestogen in hormone replacement therapy after the menopause. And then now I invite Johannes to come to join us again. We will start with the question and answer. We have received a huge series of questions, and then I'm very happy to start. Okay, then it is one question from Johannes for you, from Ivan Martin from Valencia. All meta-analysis show that progesterone in all routes and preparation are sufficient after oocyte retrieval. Yes, that is so, but all are based in old studies that used HCG 10,000 units. That is the most important luteal support. Now, using lower HCG dose, do you think it is still true that all progesterone preparation are the same?
That's a very good question. Thank you for that one. This has been evaluated recently. There's been a study in Repro Biomed Online in 2022, and they randomized the patients into 4 regimens, and they had different HCG doses in the groups 1, 2, 3. And then they had the applications of 17-alpha hydroxyprogesterone caprate intramuscularly for luteal phase support. So that should not affect your progesterone levels too much. And what they showed was that indeed, with an increasing HCG dose for triggering, the progesterone levels increased a few days after the trigger. So you had the lowest progesterone levels with 5,000 units and the highest with 10,000 units. So that's true. But they had a 4th group, and this 4th group was the medium HCG dose of 6,500 international units, together with the classic vaginal progesterone of 200 milligrams 2 times daily. And what they could show that this regimen was very much alike the high dose 10,000 HCG regimen without micronized progesterone. That's why we can assume that the doses that we provide are even sufficient for the patients where we use 5,000 international units, but there are no direct studies, no clinical studies, because we would need very, very large sample sizes. So it's a very good question. I assume it's okay, the doses that we use, but it's a wonderful question. Thank you very much.
Thank you, Johannes. And then now one question for Alfred Mueck. Alfred, you mentioned that the gold standard for the choice of hormone replacement therapy is transdermal estradiol plus progesterone, maybe with the exception in patients with bleeding problem. What is your experience about this? How would you treat this patient with these complications?
I can say that we have the complication, especially in China. The Chinese women, Asian women, have about 25% bleeding problems with the progesterone. And in Germany, I have about 10%. So I have the bleeding problems. For this reason, why we established the outpatient hysteroscopy for the bleeding problems, to look if the problem is polyps or others. When we have excluded pathological problems, we mostly make the progestogen challenge test, so-called hormonal curettage, using a synthetic progestogen. In Germany, I mostly use the clomidinone acetate, 4 milligram, given 10-12 days, and this induces a withdrawal bleeding. I measure endometrium, should be less than 6 to 7 millimeter. If still high, I repeat this progestin challenge test, and then I can start with the HRT. In China, we have good results with the dydrogesterone. Often people say that dydrogesterone is not very effective in an endometrium, and this is not true. So it is really a good choice when we have the bleeding problems. And I can say that the bleeding problems with progesterone are there, but it is also told by the people that progesterone may be enough when you give it in higher dosages. There is a study where we have the replenish study, where we have a new preparation, the oral estradiol 1 milligram and progesterone 100 microgram in one tablet. And in this study, there was within 1 year no hyperplasia, but only 300 patients have been moved. So I have to say also progesterone may in most patients be enough efficient in endometrium. By the way, I think there was also an author in this study, Andrea, they did not see a VTE in this risk. And I will see in future how this will develop with oral estradiol and progesterone. So the summary is, when I have bleeding problems, I increase the dosage of progesterone, and I first make a so-called hormonal curettage. But I have to exclude, of course, pathological bleeding problems.
Thank you, Alfred. And then now one question for Johannes. What gestogen do you use in recurrent miscarriage?
Okay, yeah. Basically, I was waiting for the question because it always comes up. These days, as I said before, I'm using the vaginal micronized progesterone because of this last analysis, the large network meta-analysis that I was showing. And but you can discuss that because some studies also showed that dydrogesterone would be of use, and these large meta-analysis showed that it would only help in threatened miscarriage, so when the patient would already have a bleeding. So sometimes I'm using only this because it's more the standard nowadays, and sometimes I'm mixing it with oral dydrogesterone, and I'm providing both to the patient with the idea of that it's very unlikely that you will do any harm to the patient by giving her both regimen.
Thank you. And then one for Alfred. Which dosage do you recommend using transdermal estradiol and micronized progesterone?
So we use with a transdermal estradiol, we start with a middle dosage, which is 50 microgram. This means 2 hub of a gel or a 50 microgram patch. And we add for 14 days. That means in a sequential regimen, the progesterone, even orally 200 milligram or in the evening to have the good sedative effect. And if we have regular bleedings, this dosage is okay. And this was also the dosage in studies where they looked at the breast cancer risk and also in studies looking at endometrial cancer risk. So we have good results with this also regarding endometrium, for example, in the PEPI study. But own experience is that you often need more oral estrogen. What you can do, you can give the progesterone, the capsules vaginally. So we give the 200 milligram vaginally twice per week and give it twice per week. And this is a continuous combined regimen. But the regimen is not so easy to find it. I would say that often we have to increase the progesterone dose, which is not a problem because progesterone is very good tolerable.
Then a question from Michel Moreau. Johannes, for you. This is okay. I will read. Dr. Ott, for luteal phase support, can oil-based micronized progesterone be administered orally rather than vaginally?
That's a good question. I think we do not have sufficient literature about that. Presumably, yes, but we don't really know the dose, and there are no recent studies about that. That's why we're not using it at our department.
Okay, and then from yes, please, Alfred, you can.
I would like to add that there are really very different pharmacokinetics and pharmacodynamics vaginally and orally. You have different metabolites, as you know, and metabolites may be also important for the effect what you want. So I would never compare vaginal studies vaginally with orally. This is a really very different regimen because you have so many metabolites with the oral progesterone.
And then now from Maya Banovic, a question for Professor Mueck. Is artificial frozen embryo transfer with estradiol and progesterone is safe for cancer survivors? the serum level are too small compared to ones during pregnancy. And then, you know, sometimes cancer survivors, they decide to have a pregnancy. And the question is about the safety of estradiol and progesterone given for the frozen embryo transfer. But
there is a controversial discussion about this. Most people say it is safe, but the discussion is controversial.
Thank you.
Sorry, I do believe if you would be looking at the patient population, which would be large enough, you would find some kind of significant effect. But I guess that if there is an effect, it shouldn't be too large. So I think after correct counseling and providing information to the patient, I think you can do it. You cannot rule out that you slightly increase the risk for recurrence, but I think the effect would only be modest.
Thank you. And then a question for Alfred. What dose of drospirenone would you use with transdermal estradiol for HRT? The 4 milligram dose found in the products like that are used for contraception or any other dose? This is from Andorra Jackson.
I think the dosage of 3 milligram would be enough for continuous combined therapy. For example, like in Angelique. So I think 3 milligram give enough secretory transformation of the endometrium. But the question is good because drospirenone is very similar to progesterone and the endometrial efficacy not very strong. So I would look at bleeding pattern and on endometrium treatment during treatment with drospirenone.
Thank you. And then for Johannes from Raha Maroil, regarding the preeclampsia risk from the supplementation of progesterone, for how long it can be done?
We don't know. So these data that I was showing come from only the first trimester, and these patients had been treated for other reasons than for preeclampsia. So that was kind of a beneficial side effect. So we don't know in the end. Of course, if you find an increased risk during first trimester screening with uterine PIs being increased, you will, of course, provide acetylsalicylate acid as usual. And I think that this progesterone treatment cannot be considered a standard yet. But it's nice to know that it could be an option in the future, probably in addition to other preventive measures.
Thank you. And then now for Alfred from Sabine Steyman. Can you tell us about levonorgestrel and estradiol transdermal and the risk of breast cancer?
Our studies that we have no increased risk of breast cancer compared to copper IUD, and there are studies that there is an increased risk of breast cancer. When you ask the company, give no clear recommendation on this. So there are different results on the studies, but I would say the risk is there, but very small. The risk is there because we see a very strong proliferation effect adding the levonorgestrel to estrogen-primed breast cancer cell. So levonorgestrel has a strong proliferating effect. So even very low dosages, I could imagine that there is an effect. And we know that IUD can have systemic effect. So we know there are more follicle cysts when you use the Mirena. So we have the HDL effect, which goes down. So we have a proof that Mirena can have systemic effect. So I would not exclude systemic effects in the breast, but they are very low.
Thank you. And then a question from both of you, because, you know, the question is from an anonymous, but this is such a topic which is sometimes we are hearing a lot about that. What do you think from the risk of meningioma in France with all progestogen? It's astonishing that the question is in French. As this is in French because they are looking about that one, or because these have a greater presence and it has never been seen in other countries at the same level. Do you have any idea?
We have always mostly progesterone receptors in those patients. I think we have an increased risk with the different progestogens, and I would monitor it clinically, but I would not, I would use the contraceptive pills. But it seems that there are differences between the progestogens. So in the studies, we have a difference between the norethisterone type and the progesterone type.
Yes.
So,
Yes.
so I would look at the studies and use not the progestogens which we have in the studies which see an increased risk. The same question is for glioma. We have looked at about dozen studies on glioma, and there are most studies with no risk, but 2 studies from UK with an increased risk.
Then for Johannes, when is from an anonymous, when do you dose progesterone in order to check the luteal phase deficiency?
When do I dose progesterone in order to check
in order to decide if the patient should have a luteal phase deficiency?
When do I decide that she has that? That's a difficult one because, as I said before, these progesterone increases during the second half of the cycle dependent from GnRH and LH. So one measurement of progesterone can lead you to a false result. If the patient has a deficiency and you come directly after the only one GnRH search that she has during the day, you will think everything's normal, and you can also have it the other way around. So basically what has been suggested is to make 2 or 3 measures within one day, within a few hours, and then take the mean value of progesterone. So that's probably the thing which is most reliable according to studies. But it's a difficult topic. That's why we always usually provide for IVF and recurrent miscarriage patients progestogen supplementation, some kind of supplementation, because you cannot be sure with progesterone measurement alone.
Then a question for Alfred. Alfred, Professor Mueck, would you in general recommend screening for breast cancer risk by assessing membrane-bound receptor in the blood?
We do it in patients with...
Because your publication was very indicative for that point.
Yes. I think because we have now a good assay which was developed and can be also is available in the labs. So it is not very expensive. I would recommend it, like we recommend also other tumor markers. And our tumor marker was better than the other tumor markers compared in this study. So I would recommend it in patients with increased risk of breast cancer and in patients where I want to treat with synthetic progestins for different reasons. If we use a progesterone, it is perhaps not used, but it is not very clear the risk of breast cancer with progesterone. We need more studies. We have only the 4, and we are just investigating different metabolites of progesterone. As you know, there are 2 ways of metabolism in progesterone. One, the pregnein metabolism. These metabolites increases the proliferation of breast cancer cells, and the pregnein metabolites decreases the proliferation. So the ratio of the 2 metabolites is decisive if we would have in the long way a risk of breast cancer using progesterone. In my view, it is a very important question because all people say progesterone is the golden standard. But in long-term therapy, longer than 5-8 years, I would be careful. There is one study, the E3N study, where we had after 8 years a small increased risk of breast cancer, also with progesterone, the lobular breast cancer, not the ductal. So I would not be surprised to get a study published somewhere that we see an increased risk. But this is dependent, in my view, from the progesterone metabolism in long way. So I would propose to make screening in different directions. When we have a new mechanisms of breast cancer, which we know, we should look for this mechanism to screen for the mechanism. So we can screen for the progesterone metabolites and can decide in the individual patient the metabolism and can foresee which is the risk in this patient. Is in general my view on this breast cancer problem in HRT, that we should have more screening in mechanisms which we know about HRT and breast cancer. Another one is screening for estradiol metabolites, which we have published now in Climacteric just now. We are very sure, totally sure, that, and it is published also from WHO, that certain metabolites together with oxygen and together with stress can develop semiquinones and quinones. It can make DNA problems in the replication and can make breast cancer cells. So measuring metabolites in the screening is also an important option to avoid in a long-term therapy an increased risk of breast cancer.
Thank you very much. Now, there are some questions which should be probably done for our previous webinar with Umaidan and Barry related to the in vitro fertilization. But I would like to put a question, Johannes, if you can have the answer to that one. This is for the cryocycle. For the cryocycle is Sabine Steinman. She's asking when the progesterone level on the day of embryo transfer is normal, it is still really necessary to give progesterone additionally?
As I said before, it's a question whether you dare doing that or not. And as I said before, measurement of progesterone is tricky and kind of unreliable. So, of course, the effect is not that high. You're having an odds ratio of about 1.5 or maximum 2 for live birth. But still, it's significant, and thus I would do it, because probably you just are misdiagnosing the wrong patient, and that would really have a benefit from this treatment. That's why I don't dare doing that.
Thank you. And then Alfred, it is from Andorra Jackson. I apologize if I missed this, but there was no comment on cyclic versus continuous progesterone, in HRT. Is still considered safer for breast health to have cyclic use for progesterone?
Cyclic use means sequential, and
Yes.
1 week no.
Yes.
No. I would say there is a study, the EPIC study. They investigated this question, and they see a higher risk with continuous combined compared to sequential. So the duration of the progestogen phase is important also for the breast cancer risk. There are about 15 studies where we have a comparison of different duration of the progestogen phase. And the studies are different, but there are more studies showing that duration of progestogen phase can increase the risk of breast cancer.
Thank you. And then now from Johannes, for you, from Yoldemir Tefik. He asks, can you comment the difference between urinary HCG and recombinant HCG regarding luteal phase?
Also a tricky question. There is no good recent literature on that, especially randomized controlled trials. There's been one study being published, I think in 2010, but that was retrospective, I guess. And they show that probably there would be higher pregnancy rates after a recombinant HCG. But I don't think that we're having sufficient evidence for that. To the best of my knowledge, that's not included in any recommendations or international guidelines. And neither do we have literature about frozen embryo transfer, what a kind of HCG we should use. So I'm sorry, I cannot answer that completely.
And then, thank you very much. And then now we are approaching to the end, and then we have two questions. One is an interesting observation. This is for Alfred, for you. Is from Rafael Bedoya Torres from Mexico. Are there different effects in central nervous system between dydrogesterone and natural progesterone by their possible action on pregnenolones? And should this influence with what to use?
I think this is a question for you, Andrea, because it's your research. Of course, there are differences.
Thank you. Okay, if I can add something, certainly giving, as you know, dydrogesterone cannot be transformed to allopregnanolone by the changes in the tertiary structure of the molecule. And while with natural progesterone, you increases also allopregnanolone, either both in the brain as well in the peripheral circulation. Certainly, for some central effect, the allopregnanolone support during the aging brain have some protective effect, either for the new myelinization as well, some for the behavior for effect on GABA A receptor. But we have no studies comparing on this point.
But you have very excellent research on progesterone. But dydrogesterone has only one main metabolite, which has no
And then now we are approaching to the end. Then we have one question, interesting question from Gérard Boutet for Johannes, for you. Thank you very much for this meeting. And for Professor Ott, is your luteal phase support strategy the same for endometriosis patients?
In IVF? Basically, based on literature, I would say yes, but we're adding a little more gestagens in many patients. Because of this assumption of progesterone resistance in these women, genetically based progesterone resistance. And that's why usually we're combining vaginal micronized progesterone and oral dydrogesterone.
In endometriosis, good studies only in normal patients with dydrogesterone up to 100 milligram from Schweppe published. Very good tolerable. And we have checked different dosages. So 20 milligram dydrogesterone is a similar dose like 2 milligram Dienogest for endometriosis patients. So I think dydrogesterone could be a good choice in this question.
Okay.
But you wouldn't use Dienogest for luteal phase
no,
after IVF, yeah.
I just say it comparing the symptoms of endometriosis.
Yeah, thank you.
Thank you, thank you. Okay, then we are at the end of our time, and I would like, as normally happen in this webinar, you remind, I would like to ask a special comment, a final comment at the end on their topic, but also on what they believe in general. We started at the beginning from Johannes and Alfred. Now I will start with asking to Alfred and then Johannes. Alfred, your final comment on the area of progestogen use after the menopause.
My final comment?
Yes.
I think it is clear that we have a certain golden standard, but we are happy to have different progestogens, and we should consider the different pharmacological properties on the receptor level, on pharmacokinetics, and clinically in certain endpoints like plaque stability, etc.
Thank you very much. And then Johannes.
I'll start with the same wording as Professor Mueck. We have golden standards for the treatment, and I try to present the current knowledge. But I think we also have to think about individualized patient care because there are some new studies, for example, showing that after frozen embryo transfer, the additional luteal phase support with dydrogesterone in addition to a micronized vaginal progesterone is even better in some women with suspicion of luteal deficiency. So we shouldn't forget about individualized patient care and what the patient wants from us.
Thank you very much. And then it was a fantastic webinar. You know, in conjunction with the previous one with Humaydan and Barry, we have faced the problem of progesterone from adolescence until the late age in older patients, looking at what happened during the menstrual cyclicity, during the endometrial protection, looking what happened during the fertilization process and so on, the in vitro fertilization, looking what happened to protect the endometrium in women who don't need any pregnancy but want to be protected. They can have progesterone deficiency, which are associated also to the difficulties that we have in our daily life. And this is also, I have to remind, the negative effect of stress on ovarian function. And later on, we move to the menopause and after menopause until elderly. And Alfred Mueck was showing us what is important, the support of the woman, and what's important, the best choice of the progestogen and the different progesterone use, and how we can go and help our patient until to reach the elderly and to reach the final moment. Then, dear friends, thank you very much for being with us. Thank you, Alfred. Thank you, Johannes, for your time and for your dedication for the European Society of Gynecology. And next, dear friends, now I want to tell you that we will have the next one. The next one webinar is astonishing for the title, which was proposed by Andrei Milevich, the role of juvenile hormones in women from adolescence to old age. And the two speakers will be Andrei Milevich and myself. Andrei will speak about adolescence, reproductive period of life and pregnancy, and I will speak about from climaterium to the old age. And with that, I thank all of you for being with us, and I remind you that we will have 29th of November, 2nd of December in Amsterdam, the Congress of the European Society of Gynecology. We wait all of you. Thank you for being with us, and to see the Wednesday, 26th of April, always at 3 o'clock for our next webinar. And this is the beautiful skyline of Amsterdam, where we will enjoy all together at the 15th Congress of the European Society of Gynecology. Thank you for being with us. Thank you, Johannes. Thank you, Alfred, for all your time and your dedication. It's strongly appreciated. All the best.